Thank you very much. All right. Well, good afternoon, everyone, and welcome to this presentation, and thank you for coming along. My presentation is on JBI PACES, a software tool to support evidence implementation. My name's Alexa McArthur. I'm a Senior Research Fellow at JBI, and I would just like to acknowledge that I'm presenting on the traditional country of the Kaurna people of the Adelaide Plains, and I pay my respect to Elders past, present and emerging. I would also like to acknowledge my co-authors for this presentation, as listed on the slide here, Zach Munn, Lucylynn Lizarondo and Craig Lockwood. And I would just like to, they're all colleagues with me who work at JBI, and so I just want to disclose that. So I just want to start off really just painting a bit of a picture. And at JBI, we have contextualised the steps involved in the process of achieving an evidence-based approach to clinical decision-making through the JBI model of evidence-based healthcare. And one of these components is evidence implementation, where we focus on implementing findings from systematic reviews, trustworthy clinical practice guidelines and other evidence-based resources into policy and practice. But we know that evidence implementation is very challenging work. Primarily, obviously, it involves clinicians, but it also involves researchers working with clinicians and policymakers across all different health professional backgrounds to help to lead change initiatives to facilitate the implementation of evidence-based approaches to healthcare. And at JBI, for many years, we have conducted a flagship short course program of ours called the JBI Evidence Implementation Training Program, which was formerly known as the Clinical Fellowship Program. And we have worked very much to develop a pragmatic approach to evidence implementation. So based on the JBI model, we have extended this into the JBI approach to evidence implementation that looks at these various phases. And so really it gives clinicians, I guess, a process or phases to really be able to work through and work on their evidence implementation program. And we teach about all the various implementation frameworks, theories and models, and they can incorporate them into their evidence implementation projects as well. And this leads me on then to talk about JBI PACES, which is a web-based application for helping to assist in implementing evidence into practice and looking at quality improvement initiatives. And it will really helps to assist health professionals and those in quality improvement areas to improve their performance in line with the best available evidence. So the acronym PACES stands for the Practical Application of Clinical Evidence System. And it is software that is used to support evidence-based practice, quality improvement projects, can be used for different types of research projects. And it's really based on the audit and feedback cycles. Now, JBI PACES has had a former version around for quite a few years, probably the past 10 to 15 years, and it was in urgent need of an update, and it has been totally redeveloped and has just been launched in the last month. So I just want to run through this, and it will just be a very quick run through about what JBI PACES can offer in the evidence implementation space. So when we're considering the different type of clinicians choosing a topic for their implementation project, it will always be based on evidence from, and at JBI, we derive this evidence from our JBI evidence summaries, which come from the JBI evidence-based practice database. And then this is in that you are able to access this through JBI PACES software. And this really then also leads into the development of audit criteria, which are evidence-based. And these are well-defined standards that are set on the principles of evidence-based healthcare. And then they can be drawn to, for clinicians to be able to measure their compliance and to help to evaluate their current practice against best practice. So you're able to search, select and create audit criteria. And within JBI PACES, you can access the database of evidence summaries and audit criteria. You can select from these pre-existing audit criteria for your project, but you're also able to add custom audit criteria within that might need to be have been contextualized from within your setting. And there's different types of criteria. So it might be as Boolean criteria, ranges, or continuous data. And there are a number of different projects for your different needs, and you can tailor this to different types of research projects or within your evidence implementation project. You may have want to do a one-off project. You may want to do an ongoing project where data collection happens over many weeks, months, or even years. And primarily people undertaking an evidence implementation project will have multiple data collection periods, so they will do a baseline audit and then a follow-up audit. When you have collected your data, you are able to then generate these compliance reports, and you're able, and here's an example of the baseline audit results. And you're also able to export this data into a variety of formats, such as Excel, if you want to undertake further analysis. What we really want clinicians to do is to focus or have a look at their baseline audit results, and then we want them to really, I guess, go into more detail as to what are the barriers to explore, why aren't they able to meet or, the compliance, and how can they improve their practice in this clinical area. And this is called the GRIP module, Getting Research into Practice, where they can explore barriers, enablers, and identify strategies and implement strategies to overcome these. After they've undertaken the GRIP phase, they would conduct a follow-up audit, and we obviously want clinicians to be able to reflect on those strategies that they've implemented and to evaluate the changes that the evidence-based practice has had in their facility, and has it really affected outcomes and made an impact. And a future feature for PACES will hopefully be the ability to track outcome data in relation to the compliance data. So this is something we're planning for the future. So just to summarise the features of JBI PACES, very much it's aligned to the JBI implementation approach, which is firmly grounded in the audit, feedback and re-audit process, supporting a structured approach to the identification of stakeholders, barriers and enablers, and the development of implementation strategies. So very much we see the strength of JBI PACES, its ability to support a small scale project or a larger research quality improvement project where you can do single site audits, or you could do a multi organisational level implementation project across an organisation. And realising the complexities of evidence implementation, it's really to support clinicians in their evidence implementation work. I just list some references here, and if you would like any further information, please do email the JBI PACES email on the screen. So thank you very much, and I'm happy to take any questions.
Thank you very much, Alexa. If anybody's got any questions, feel free to put them in the chat or raise your hand. I'm not seeing any, so I might start with one. Alexa, you mentioned that you'd recently, I guess, revised the system. Can you tell us kind of if there are any big changes or what were kind of key things you think have come out in this newer version?
Yeah, look, I think one of the main features, Emily, is, well, it's a lot less clunky, it's a lot more streamlined, so it's much more user-friendly, which is a great plus from the IT side. But I think one of the really important things is that you can customise the audit criteria. And what we have found with over many years of working with clinicians is that the audit criteria that it's been drawn from evidence, but within clinician-specific context, there's often that amount that they just need to make some changes for their particular setting to make that audit criteria customisable, and that's a feature now of the new PACES, which is fantastic. So there's many more features, and sorry it's such a short presentation, but please to get in touch with us if you're interested.
Great, and there is one question on the chat asking if it's freely available.
It's freely available if you undertake one of our evidence implementation training program. It's part of the short course fee, but no, it's for purchase.
Wonderful.
Through our commercial partner, Walters Kluwer. So if you do want more information, please do get in touch.
Wonderful. Thank you very much. Really interesting presentation, Alexa.
Great. Thank you.
We will move on to our second speaker, Victoria Ramsden. If you want to go ahead, Victoria, and share your screen.
Just confirming you can see that?
Yes, thank you.
Fantastic. So welcome to this session on sustainability of evidence-based practice in the management of infants with bronchiolitis, a PREDICT study. My name is Tori Ramsden and I'm an MCRI PhD student working collaboratively with investigators from around Australia and New Zealand to complete the study. I would like to begin by acknowledging the traditional custodians of the land on which we gather today and pay my respects to elders past and present. So the Paediatric Research in Emergency Departments International Collaborative, or PREDICT network, includes research institutions, healthcare providers and researchers involved in paediatric emergency care across Australia and New Zealand. With a vision to establish an evidence base and improve emergency care for children and adolescents through rigorous research, it is the largest paediatric emergency medicine network in the Southern Hemisphere and is currently a National Health and Medical Research Council funded Centre for Research of Excellence. In infants less than 12 months of age, bronchiolitis is one of the most common lower respiratory tract infections. In Australasia, it is the leading cause of hospitalisation in infants under 6 months of age. Whilst management of bronchiolitis is well defined, comprising of supportive practices such as supplemental oxygen and fluid replacement, variation in practices still occur. The Australasian Bronchiolitis Guidelines recommends against the use of inhaled salbutamol, chest x-rays, oral glucocorticoids, adrenaline inhaled, and antibiotics in the routine management of bronchiolitis in infants. So in this presentation, when I refer to the 5 practices, these are the practices that we are measuring. So a little bit of background. The knowledge translation in Australasian Paediatric Acute Care Setting Study, which I'm going to refer to as the previous KT study going forward, was a multi-centred clustered randomised control trial conducted in 26 Australian and New Zealand emergency departments and inpatient paediatric areas during the 2017 bronchiolitis season. The intervention group received targeted theory-informed interventions, which comprised of identification of clinical leads, stakeholder meetings, train-the-trainer workshops, education materials with scripted targeted messaging, as well as a patient video, evidence fact sheets, and finally monthly audit and feedback. Findings demonstrated that targeted theory-informed interventions significantly improved compliance with these 5 key non-evidence-based practice recommendations by 14%, with some sites going up to 21%. At the end of the study in November 2018, control hospitals were provided with selected intervention material, including a 1-day workshop, education materials, patient video, and an evidence fact sheet. So the primary aim of this study is to determine if interventions from the previous KT study have been effective in sustaining improvements 2 years after the study completion at the intervention group hospitals. Other aims are to determine if there are any improvements in control group hospitals, to understand the factors which influence the sustainability of improvements in intervention group hospitals, and to explore factors which may have contributed to the improvements at control group hospitals. Sustainability can be seen in 2 ways: the continued improved clinical care process measurement and the continued clinician behaviour change. And sustainment is the continued use of the implementation targeted theory-informed bronchiolitis intervention. So we will undertake a retrospective medical audit and qualitative semi-structured individual or group interviews with all 26 hospitals which participated in the previous KT study being invited to participate. The primary outcome will look at the proportion of infants with bronchiolitis at the intervention hospitals who received care that adhered with all 5 practices 2 years following the delivery of the interventions, which is a composite of all 5 practices. Secondary outcomes will look at a composite outcome of the proportion of infants with bronchiolitis who received care that adhered with all 5 practices at 1 year at intervention group hospitals and 2 and 1 year at control group hospitals. A priori exploratory outcomes will examine adherence to the 5 individual practices, differences between the groups in both 2019 and 2018, as well as trends over time. Data for the retrospective medical audit will be analysed at the patient level according to the group the hospital was originally randomised to, using descriptive statistics and generalised linear mixed models. There is no consensus in the literature on how to quantify sustainability, so the investigators agreed that we would define improvements based on the previous KT study data, which calculated the median improvements for both the intervention and control group hospitals as 7% using a composite outcome of all 5 practices. 4 years post-implementation, qualitative interview outcomes will examine factors that contributed to sustainability of improvements in evidence-based practice adherence at both intervention and control group hospitals, as well as fidelity and adaptation to the previous KT study implementation strategy using the Consolidated Framework for Sustainability Constructs in Healthcare. We will conduct the qualitative semi-structured group or individual interviews with 3 to 5 individuals per site from a cross-section of medical and nursing staff from both ED and inpatient areas. Where possible, we want to include the clinical leads from the previous study. The semi-structured interviews aim to determine how the previous KT study was perceived by staff, the use and adaptation of intervention materials, and barriers and enablers to sustaining practice change. Data will be analysed using thematic analysis. So where are we currently? So currently we have received ethics approval for the Australian sites. We will be commencing ethics for the New Zealand sites. We have registered the study with the Australian and New Zealand Clinical Trials Registry. And finally, we have commenced Australian site recruitment with 14 sites agreeing to participate currently. So thank you very much for listening to my presentation, and I will now open it up for some questions.
Thank you very much, Tori. That was incredibly interesting. I'm not seeing any questions in the chat yet. I haven't seen any hands up. I might just ask maybe a bit more of a practical question. It's really interesting that you're able to go back 2 years, I think it was, after the original implementation. How have you gone getting those same hospitals to agree to participate? Were they generally interested, or has it been a difficult process?
So far, when we've approached the clinical directors, majority of them have said they're interested, which has been fantastic given the current situations. A lot of them are interested to see what has happened since implementing it, and has there been have the improvements been sustained. So it's been pretty positive so far.
Fantastic. Any other questions?
Sorry. About that. Are you seeing my screen all right, my slides?
Yes, thank you so much.
Okay, so yes, good afternoon. My name is Lucylynn Lizarondo, and I'm presenting on behalf of my colleagues at JBI in the implementation science team. So I'm currently employed as a research fellow in JBI, the University of Adelaide in South Australia. And as part of this role, I teach in the JBI Evidence Implementation Training Program. So this presentation is about the Delirium project, which I've been privileged to be involved with as part of the JBI Evidence Implementation Training Program. So there's this group of nurses from a large tertiary hospital in New South Wales. They collaborated with us to improve their delirium practices and outcomes using the JBI Evidence Implementation Framework. So just before I talk about the Delirium project, so let me first present to you the JBI approach to evidence implementation. So the JBI defines evidence implementation as purposeful and enabling set of activities designed to engage key stakeholders with research evidence to inform decision-making and generate sustained improvements in the quality of healthcare delivery. Now, integral to our approach are context analysis, facilitation of change, and evaluation of process and outcomes. The JBI approach is also firmly grounded in the audit feedback and re-audit process and on a structured approach to the identification and management of the barriers to change. So as you can see from the slide, there are 7 phases to the JBI Evidence Implementation Framework, and I will go through each of these phases as I talk about the Delirium project. So many of you might know that in Australia, there has been a growing awareness and concern about delirium, with delirium being identified by the Australian Commission on Safety and Quality in Healthcare, or ACS-QHC, as a high priority area for quality improvement. So in 2016, the ACS-QHC released the Delirium Clinical Care Standard to ensure that patients who are hospitalized and at risk of delirium are identified early and they receive preventative strategies. So in recognition of the Delirium Clinical Care Standard and also as a response to the cumulative rate of hospital-acquired delirium, the nursing department of that large tertiary hospital in New South Wales launched a hospital-wide evidence implementation project to facilitate the implementation of best practice in delirium care and optimize their patient outcomes. So for phase 1, which is identifying practice area for change. So prior to us being involved in this project, the organization had already identified issues that impact on their delirium practices, which obviously became the impetus for changing or initiating the practice changes. So this included a general lack of knowledge about delirium and its management, lack of a locally agreed screening and assessment tool, and the absence of a hospital-based policy and procedure for screening, assessment, prevention, and management. So for phase 2, in terms of engaging change agents, so right from the start, there was strong leadership support from their executive team. The nursing unit managers were also actively engaged, and they agreed to ensuring protected time for staff leading the projects. There was also a call for expressions of interest from registered nurses who were interested in acting as change agent for each participating ward and have a strong interest in delirium care. So they were to be the delirium champions. The comprehensive care nurse manager and the nurse manager for clinical practice and innovation oversaw the project. And then from us at JBI, 2 implementation researchers acted as facilitators. So we assisted with the project, ensure projects progress as planned. We provided feedback and as needed support to the delirium champions. For phase 3, context analysis and determining the readiness for change, the delirium champions collectively perform a situational analysis via roundtable discussions. And they considered resource availability, interdisciplinary relationships, workplace culture, leadership support, communication, knowledge and skills of their healthcare staff, and their commitment to quality management. And that confirmed the organization's overall readiness for change in terms of delirium practice. For phase 4, which is reviewing practice against evidence-based audit criteria, so we as facilitators summarize delirium clinical guidelines as well as the clinical care standards, and distilled them into audit criteria, as you can see from the slide. So a baseline audit was then undertaken against this audit criteria in the participating wards, which were known to represent patient groups at high risk of developing delirium, and that included ED, a specialty medical unit, hematology and bone marrow transplant, palliative care, heart and lung stream critical care wards, rehab, mental health emergency services, and an acute aged care ward. For phase 5, which is the implementation of changes to practice, so following their baseline audit, the Delirium Champions held group sessions with their project teams to identify barriers to compliance with the recommended practices as reflected in the audit criteria. So barriers analysis revealed that there were health practitioner related and organizational level factors that hindered compliance to recommended practices. So what we found was that, and not surprisingly, nurses generally lacked confidence and had limited knowledge about the assessment and management of delirium. There was also a general lack of awareness regarding information resources about delirium and support for patients and their families. On an organizational level, there was no locally agreed standardized tool to facilitate screening and assessment. There was also the absence of a hospital-wide policy and procedure for delirium management. So given those multifactorial causes of non-compliance to recommended practices, a multi-component strategy was implemented by all delirium champions in their respective units or wards. The reassessment of practice.
Lucylynn, I'm just going to jump in there. I'm sorry, we seem to have lost your sound. Lucylynn, can you hear us? Okay, she seems to have lost sound and maybe back to us.
Yeah, I'm just looking, Emily, and it seems Lucylynn's not muted, so it's a bit mysterious.
Lucylynn, can you hear us?
No, okay, yeah.
Oh, back.
I think we might be able to hear you again, Lucylynn. Could you say something?
So was it like this right from the start?
No, we got most of it. If you want to go back to, and then, yeah, you cut out maybe just a minute ago. You want to go back to your slides?
Okay, so I'll just share my screen again. So just this one?
Yeah, I think it's the key points that we missed out. So if you just want to, yeah,
okay. So
repeat that. Thank you.
Okay, so I'll just go back to this one. So at this stage, I think I was reporting around the barriers that the delirium champions were able to identify. So, and after they have identified the barriers, they've implemented multi-component strategies. And then following the implementation of those strategies, they did a follow-up audit to determine compliance with best practice recommendations. So as you can see from the slide, the compliance rate for all audit criteria improved as shown in this slide. And the rate of hospital-acquired delirium at this tertiary hospital also decreased post-implementation. Now for phase 7, which is the consideration of the sustainability of practice changes, so the delirium champions convened with the facilitators from JBI to discuss strategies for ensuring practice improvements and also planned for future audits. And the areas of focus for further improvements, which really focus around educating patients and involvement of the carers, were identified and prioritized. So in conclusion, the JBI evidence implementation framework provided a structured approach to clinicians and led to the development of evidence-based resources and locally agreed policies and procedures, which resulted to improved screening and assessment practices and early intervention for those at risk of delirium. So that's the end of my presentation. Sorry about that.
No, thank you so much, Lucylynn. We've been saying there's a bunch of tech issues that comes with virtual conferences.
Yeah.
In the interest of time, I think we're going to have to skip questions and move on to our next presentation. But I'm sure if anybody has any burning questions, they can drop you a message or send you an email. And we might move on to the next one, which is actually the pre-recorded one by Rona.
This approach was informed by both implementation science and qualitative methodology, and the work was conducted in Melbourne, Australia. The starting point for this work was the iPredict study, which was part of a multi-centre feasibility study conducted in Melbourne to explore using complex genomic sequencing in oncology care with advanced cancer patients. As part of the project evaluation, we collected data from healthcare professionals, that is oncologists as well as laboratory scientists involved in delivering the service. The overarching aim was to explore and understand the lived experiences, perspectives, and support needs of oncologists and scientists who are involved in delivering a genomic testing service to advanced cancer patients. Qualitative data collection was grounded in a phenomenological approach using semi-structured interviews to understand the lived experience of the workforce. An inductive-deductive hybrid approach to thematic analysis facilitated a more rigorous process as well as greater applicability of the findings, and therefore the codes and themes were developed from the data as well as guided by the key themes outlined in the interview schedules. The interviews revealed a number of challenges faced by oncologists and scientists across the clinical process of undertaking complex genomic sequencing for a patient. There are 7 steps in the clinical pathway, and the challenges that we identified focus on 5 of them, highlighted in that slide. The 5 key challenges revealed in interview findings were undertaking patient consent discussions, interpreting, disclosing, and using results from the test in clinical decision-making, discussing potential germline findings with patients, acting on recommendations for follow-up testing, and identifying appropriate tumor tissue for testing. Now I will describe the 4-step approach that was undertaken. In the first step, these challenges and related sub-challenges were mapped to the domains in a well-known implementation science framework, the Consolidated Framework for Implementation Research. This is a theoretical framework that is designed to assess potential contextual determinants of implementation. It may be used as a framework to guide the development and evaluation of an implementation strategy, as well as for the investigation of barriers and enablers to trial implementation. Similarly, interview data revealed a number of proposed strategies to address these challenges. These strategies were derived from tacit and experiential knowledge, as well as strategies which were already embedded in some practice settings. Some strategies were proposed to directly address a noted challenge, while others were mentioned in passing as strategies which could contribute to optimizing service delivery in the future. In step 2, we mapped these strategies to those in the expert recommendations for implementing change, the ERIC tool. The ERIC tool is a list of 73 discrete implementation strategies that can be used as building blocks to plan implementation and potentially address anticipated barriers. This slide provides an example of the first and second steps that were undertaken to map ERIC strategies to cipher domains and constructs. The challenges and strategies identified from the interview data are in the columns on the left, and the domains that they were mapped to in the two frameworks are listed on the right. This slide describes step 3. Once the challenges and the proposed strategies were mapped to the respective domains in Cypher and ERIC, we use the Cypher-ERIC matching tool to determine which strategies to retain or exclude based on what the evidence suggested. The tool identifies the top 7 ERIC strategies endorsed as appropriate to address a challenge mapped to a specific Cypher domain by 50% or more experts. This is considered level 1 evidence, as well as by 20 to 49.9% of experts. This is considered as level 2 evidence. Strategies not endorsed by at least 20% of experts as appropriate to address the associated Cypher domain were excluded from the final compilation of strategies selected for inclusion to address a specific challenge. And this approach allowed the qualitative insights gathered from the workforce to be used in co-design processes for intervention development in a rigorous manner, guided by the implementation science evidence base. The preceding 3 steps led to step 4 that is described here, and in step 4 we developed an online tool that is intended to be used with a group of oncologists in a focus group discussion. We want to understand their views on the types of strategies which would work best to address a specific related challenge embedded within a specific support model or model of care, which can take the form of either support from experts located at a central site, support from locally trained clinical champions, or through point-of-care resources. And the focus groups are intended to be conducted in the coming weeks. Finally, in terms of what this 4-step approach means for practice, we feel that it illustrates a real-world example of how qualitative data can be married up with implementation science theory, as well as frameworks, to support the standardization of interventions. It was also an approach which is likely to facilitate better uptake of the intervention, as it is based not only on the perspectives of participants, but also on scientific evidence on what has been proven to address similar challenges across diverse settings. Finally, I would like to take this opportunity to thank all the participants who so generously spared their time and reflections with us, and the funding bodies which made this research possible, and also to all of you for your time today. Thank you.
Thank you very much for that presentation. And Rona is on the meeting today. So if there's any questions, send them through, or if anybody wants to write them in the chat or raise their hand. I'm not seeing any. I might just ask, if I'm remembering correctly, you spoke to physicians and lab techs. Do you have any plans to speak with patients as well?
Well, probably depending on what comes out of the focus groups, we will incorporate patient perspectives as well in designing what type of strategies we'll test out in that pilot phase, yes.
Fantastic. Any other questions? No? Okay, well, we might move on to our last speaker. Thank you very much, Rona. Very interesting presentation. And our last speaker in this session is Maddie Heenan. If you'd like to go ahead and share your screen and begin.
Thank you. Can you see that okay?
Yes, perfect.
Great. So thank you, everyone. It's great to be presenting on this new method of evidence review that we've been trialling at the Prevention Centre that we're calling knowledge synthesis. And this particular knowledge synthesis is focused on public health, policy, law and regulation. But before I begin, I'd like to echo the acknowledgements of country we've been hearing today and pay my respects to the Bundjalung people whose lands were never ceded and where I live and work today. So the Prevention Centre is funded by multiple state and territory health departments, as well as NH and MRC, MRFF, Cancer Council Australia and Vic Health. And we've developed the knowledge synthesis process to bring together the findings of our funded projects and collaboratively identify the collective implications of the research for our policy partners at different levels of government. This first synthesis that we're working on is looking at public health law research, and this research looks at both the direct and indirect relationships between law, policy making and health, and it's a really diverse field of research consisting of quantitative and qualitative studies ranging from decision analyses to evaluations of the effects of a law on a health outcome over time. And public health law deploys both traditional legal functions as well as other related regulatory and policy activities, including policy development, advocacy, monitoring, enforcement and evaluation. And we know that public health researchers and practitioners seek to influence the policy process to improve population health outcomes, but often research and policy decision making are conducted in silos. And so the Prevention Centre has aimed to remove these silos from chronic disease prevention research by working as a collaboration of researchers, policymakers and practitioners to ensure that policy is, to ensure that research is policy relevant, but also that policy is evidence-based. And so the knowledge synthesis really builds on this collaborative approach, and as such, a major focus of the funded work that we've done at the centre has been on public health law, policy and regulation. So the aim of the knowledge synthesis is to review the relevant research projects and to synthesise the knowledge generated by this research and to summarise their implications for future policy making and research. It's a different process to a typical systematic or rapid review. And as I mentioned, it's an extension of our collaboration and co-production approach, with each synthesis having the involvement of a research content lead, a communications lead and a policy lead. The evidence is selective from the Prevention Centre research and expertise. So it's not meant to be, and it doesn't claim to be, a review of all the evidence in a given area. The emphasis is on identifying, drawing out and synthesising findings and expertise from across our programs of work to generate new learnings and insights. So the first step in the process is to establish the synthesis focus from key topic areas that are relevant to our policy partners. So in this case, policy, law and regulation is the synthesis focus. And then the second step's to engage the project team, consisting of the research, communications and policy leads. And then following this, conducting a policy and research dialogue where researchers meet with the policy partners to present an overview of existing research in a given area and then identify the main policy questions arising from that field. The research lead then further develops the project plan in consultation with the project team. And then following this, the research lead undertakes data extraction, identifying relevant projects, peer-reviewed publications, reports and findings briefs, and then prepare an initial synthesis of the key findings to then meet with policy partners in a second dialogue to jointly consider the implications of the findings for policy research and future practice. And the synthesis is then finalised and translated into a variety of research, policy and communications outputs. So, it could be reports, policy briefs and other outputs like that. So for the current synthesis on law, policy and regulation, we wanted to know how studies have focused on this topic, what their implications are for our policy partners, and the implications for future research. Projects and outputs were identified and obtained from the Prevention Centre website, and they were included if they focused on law and regulation or big policy issues that set the regulatory agenda. And they were excluded if they were observational or epidemiology studies that provided more background and context and didn't explicitly mention regulation or policy. They were also excluded if they focused on implementation science, modelling or various targeted programs. Data was then extracted, drawing the legal, regulatory and big policy focus, as well as the research focus and the public health topic, stage of policy cycle, the jurisdiction or level of government, and the key findings. And then we undertaken a thematic analysis of those key findings. So through this process, we identified 53 relevant publications and reports, and there was an even split actually of law and regulation and big policy focused studies. And our initial synthesis has identified 9 major themes, which are the importance of monitoring, the presence of regulatory failures or gaps, the political environment or considerations impacting on agenda setting, implementation and evaluation, the need for or importance of engagement, collaboration and co-production, the way that regulatory design or enforcement can affect implementation and outcomes, as well as reporting specific impacts on health and behaviour, specific impacts on equity and disadvantage, and industry relationships on influencing law and policy, and then lastly, explicit involvement of systems or complexity thinking. So these are some of the high-level results to sort of demonstrate how the synthesis has been conducted. And just going back to the process that I showed earlier, we're nearing the end of our knowledge synthesis, and we're about to have a second policy dialogue with our policy partners where we'll present that research and provide some more illustrative case studies that I couldn't provide at the moment given the time. And we do intend to replicate this method in other program areas, including our health economics program and various others. So I'd like to thank the project team and my co-authors here on the screen, and I'm very happy to take some questions.
Okay, we've got time for one quick question, probably. Anybody wants to put it in the chat or put their hand up? I guess, Maddie, one maybe quick question is, what's one reflection or that you've had about this knowledge synthesis process in terms of something that worked really well?
Yeah, I guess the collaboration has been really, really useful because the topic, we have trialled it with, I guess, kind of a complicated topic that focuses on many topics really when you're looking at policy and regulation. And being able to have that engagement from our policy partners has been really useful, just to sort of, you know, make sure that things are relevant for them, and that the focus is narrowed and doesn't, you know, explode out as it often can do when you're doing reviews.
Wonderful, thank you. Well, so that brings this session to a close. Thank you all to our presenters. I think we've heard from a massive range of different implementation and translation projects that are occurring and all incredibly interesting. So we've got, you've got 10 minutes until the next session starts. So thank you for joining us today, and hopefully you'll jump onto